Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And you know, as I always tell you, this is your show. And we've had a lot of questions that have come to us about issues relative to obstetrics and gynecology, but specifically relative to cervical cancer. Since this is a highlight month for the American Cancer Society, I figured that this is the right time to bring the topic to the show. So let me introduce our guests. Right in front of me is Dr. Adrian Roznowski. Good?
That's perfect.
Good. Who is a obstetrician gynecologist at Plantation General Hospital. Welcome.
Thank you very much, sir.
And to my immediate left is Jonathan Black, who is not only an MD, but also I see you have a Master's in Public Health.
I do.
And which is very important, by the way, I believe in, particularly in OB/GYN, and is involved with Gynecologic Oncology. So welcome.
Thank you very much for having me. Happy to be here.
Good to have you guys. You know, like I said, it's rather, it's easy for me because I get a lot of questions that come from the viewers. And with the large number of viewers that we get, in fact, I'm very humbled by the fact that we have so many viewers. But this program goes all the way down to the Keys and goes all the way up to Fort Pierce. And so we have a lot of people that send us questions. We can't give them answers, but we try to bring it to the topic of the show. So firstly, let me just say, generally, you are also a, like I said, an obstetrician gynecologist, so you deal with not only birthing child, but you deal with the whole woman and the processes of being what they are and how they birth and hopefully healthy and all the diseases that are incurred. But I want to specifically view the issue of cervical cancer. So if we can start out there, I'd be very happy. Dr. Roznowski.
Thank you. Our profession is an extremely privileged one because we are doctors and we strive to be the best in our profession, but we also develop a very strong kinship with our patients through their obstetrical journeys and then their GYN's follow-up. Cervical cancer is being brought to the forefront, has been addressed thoroughly, and it's one of the cancers that we have worked in conjunction with our patient population to reduce. The incidence of cervical cancer has reduced by 50% in the past 20 years, and that's due to physician and patient compliance and adequate screening methods. Given its predilection and demographics, it is arguably the most preventive type of gynecological malignancies.
Well, you know, with reference to that, and Dr. Black, since Dr. Roznowski brought the subject to the forefront, in viewing his comments or relating to his comments, you have this very close relationship with your patients, as hopefully most doctors do, but particularly in obstetrics and gynecology, it really becomes almost individuals that are related to you. They become part of your family. And it's so difficult sometimes when you end up having problematic issues, whether it be problematic pregnancies, whether it be diseases that are affected the whole process of producing a child, things of that nature. But I'd like to focus in from the very beginning of the show to talk about the screenings that are necessary to keep that person who's part of your family healthy. So go right ahead.
So in terms of cervical cancer, I'm going to focus on that since that is the topic of the show. The surveillance and screening has changed significantly over the past 15 to 20 years. It used to be that women were screened at a very young age, sometimes the first time of sexual intercourse, oftentimes 18 years and younger with pap smears. And over the course of time, as we've learned more about the disease of cervical cancer and the way that it's caused, which is the HPV virus for the most part, and we've learned about the natural course of disease with HPV, those screening guidelines have changed. So it's been very important in our field among obstetricians and gynecologists and GYN oncologists such as myself to have a good grasp on those guidelines and adhering to those, and in some circumstances kind of using the art of medicine to follow patients using the guidelines as a backbone. And for me and my patients and Adrian's as well, Dr. Roznowski's, using these guidelines to help keep people healthy and to prevent the disease is very important. Also, in the past 10 years, we've now had HPV vaccines that have become available, and that's another way to prevent cervical cancer. As we know now, cervical cancer almost undoubtedly is a preventable cancer, and the HPV vaccine and educating providers and patients about that has been very substantial in the decline in the number of cervical cancer cases that we see. But again, not everybody's vaccinated, not everybody knows about this, and so we still see a lot of cases.
Let's stay on this HPV vaccine issue for a while. You know, in multiple visits from healthcare professionals that appear on our show, the issue of vaccines always come up. I mean, there's this unbelievable thoughts out there about vaccines causing, you know, everything from cognitive disease to autism to back. You can go the whole spectrum. Everybody talks about it with really very little, shall we say, true scientific knowledge. There's a lot of social media comment. There's a lot of contentious comment usually that occurs in what I would call the social broadcasts that are on television. But this HPV thing, to me, seems to be something which I find a lot of parents that talk to us and just colleagues that I know of, that somehow there's been an opportunity to allow their children to get these particular vaccines for HPV. Just not much different than people going out and getting flu vaccine, which has been sort of put to the side. Okay, it's okay to get a flu vaccine, but I'm not going to do pertussis. I can't answer the reason why, but you know, it's a reality. Tell me about this, because I've spoke to a couple of parents, or actually grandparents, who made sure that their children who are going off to college at age 16, 17, make sure that they have an HPV vaccine. You want to talk about that? Either one? Go ahead.
The HPV vaccines currently offered, there are 3 of them, and they range from a bivalent vaccine to a vaccine that covers 9 strains of the HPV virus. The recommendation for initiating the vaccines is from age 9 to 26 in females, and this depends on the dose of vaccination that the patients would get. If the patient is less than 15 years old and the vaccine is initiated, it's recommended they get 2 doses. If they are over 15 years old, there's an extra catch-up dose that is recommended. Now, as far as the fears regarding autism or any other developmental issues with the vaccines, I believe they are unfounded because of twofold. First, there have not been any kind of documented adverse effects on that spectrum. And second, the vaccine is initiated at the age of 9, the earliest, which is after the child would have completed their early psychiatric development. The fear of other vaccines that are initiated at the age of 1 month or 6 months or 3 months is a little bit different, because by then the parent and the pediatrician does not know what the child's psychiatric development is going to be. So any causes of autism, which is diagnosed in the early infancy, somehow may be linked to those vaccines. Those fears are unfounded as well. But with the HPV vaccine, since it's such a late initiation, though there are no such concerns.
I'm sure that you must hear it, or the questions might come to you, doctor, I'm sure, from patients.
Yeah, I think people have concerns about everything, whether it's vaccines, side effects of medications, and people have lots of questions. But I think that the HPV vaccine is a very unique vaccine in that it can prevent cancer. And I think that the benefits of the vaccine far outweigh the risks, which are very minimal. And I'd also like to add that the vaccine is available for men as well, up to the age of 21. And the reason that's important is because HPV can be transmitted sexually through various methods. And it's important that both men and women be vaccinated, because this virus can get passed back and forth. But certainly people have questions about it. And like we've already discussed, I think that many of those concerns are unfounded. And the ability to now have a vaccine to prevent cancer, I think, is outstanding and highly recommended by the people in our field.
Good. Well, we got that out of the way. Every time we bring up vaccines, we get a lot of response from people out there. The bottom line is that that it doesn't seem to be that concomitant fear relative to the use of HPV vaccines. Cervical cancer is a horrible situation. You know, there are a lot of people. In fact, we've had a lot of discussions recently, which had nothing, I guess, has nothing to do just with cervical cancer. But we did a show on the BRCA issue, so you know it came up. You know, but I'd like to just talk a bit, because the people out here that talk to us, there are two areas that you're in the top 4 on. It's always cancer, cardiovascular disease, surgical intervention, and they always want to know about minimally surgical techniques. And the fourth is usually some kind of extraordinary pain issues. Those are the 4, shall we say, most dominating factors that come from our viewers. You know, but I think in your area of concern, or your area of professional privilege, 2 of them are covered, and that's cancer and, if I'm not mistaken, minimally invasive techniques. So go at it, whoever wants to start. Dr. Black?
Sure. What I would say is that for many of the precancerous lesions of the cervix, meaning that somebody has an abnormal pap smear and then they have a biopsy of the cervix that falls into the precancerous realm, the treatment is minimally invasive across the board. And there's various options for the treatment of precancerous lesions. The earlier ones ranging from laser vaporization or freezing of the cervix, more vaporization at this point, of the abnormal areas of the cervix. And then for the higher dysplastic, or the closer to cancer lesions, there are surgical approaches. Most of those are done vaginally and taking out a part of the cervix for people who are desiring fertility preservation or the ability to have children. And for those who no longer desire childbearing or who are diagnosed with an early cervical cancer, the vast majority of these cases can be done robotically, which is a type of laparoscopic assisted surgery, or with conventional laparoscopy, where patients are able to undergo a hysterectomy, oftentimes preserving the ovaries, because the ovaries are unrelated for the most part to cervical cancer and precancerous lesions of the cervix. And in these situations, people who have the robotic or minimally invasive or laparoscopic surgery are able to go home the same day after having had a large surgery. And so we try to do everything as minimally invasive as possible, because that decreases the morbidity or the complications associated with the surgery, and patients tolerate it very well.
And let me just, as a subtext to your presentation, the reason it comes up always in the top 4 is because everybody relates to surgery as blood, cutting, and pain. That's what we hear from the people out there, and they have interpreted minimally invasive techniques, or techniques which are done through various new ways, assisted surgical techniques, they understand and they believe that you minimize the pain, the cutting, and the bleeding.
Start by saying I appreciate you calling me Adrian. I've actually eliminated Dr. Roznowski with my inpatient and outpatient staff on a large basis, which pretty much takes the hierarchy out of the equation and allows us to focus on patient care as a team. Secondly, what I tell my patients is if you're compliant and you show up to your doctor's appointments, you will not ever get cervical cancer. Even this day and age in the United States, 50% of cervical cancer cases are due to patients that have never had a pap smear. An additional 10% are due to patients that haven't had a pap smear in the last 10 years. If the patient shows up for their appointments, the chance of them getting cervical cancer is slim to none. And that is what we continuously try to stress to the patient. We know that the guidelines for pap smears are not to have one every year. We still advocate the patients to come for their GYN exams yearly to discuss any changes and any symptoms that may be a sign of an issue that we need to address. If patients come to the doctor's appointment and their compliance is high, the minimally invasive approaches that we take last as short as 3 to 4 minutes. A pap smear is very time efficient. A colposcopy, which is a biopsy done after a pap smear, takes a few minutes as well. Even for early stage cervical cancer, we can do a office procedure or an inpatient hospital procedure. There's an outpatient procedure. Now, we all know that cervical cancer is primarily a slow-growing disease. If the patients come when they are supposed to come for their annual exams and they allow us to address the issues, we can safely say that just about all of their care will be minimally invasive.
Well, I'm glad you brought that up because you know, usually I wait till the end of the show and I ask our physician participants, how often should someone come to see you?
From our standpoint, it's still an annual visit.
Right.
We do not need to see patients twice a year in the absence of any symptoms. Obviously, if they have a problem, then they need to come as soon as they're available. But from our standpoint, it's still a yearly visit.
Okay.
I would say, for the different types of cancers and abnormalities that we deal with, there are different warning signs. So I too believe that an annual visit is sufficient. However, we do review the warning signs for cervical cancer or even precancers, which can be anything from abnormal vaginal discharge, pelvic pain, bleeding after intercourse, as well as a few others. And if people were to develop those during that 1 year period, then certainly they should come as soon as possible to be seen and evaluated. So I do believe that in some instances, seeing a physician more than one time a year is beneficial and indicated. And certainly there are people who get into the pipeline of precancerous lesions and surveillance that are being seen more than once a year for that purpose. But generally speaking, as long as you're having annual exam, I agree with Dr. Roznowski or Adrian that's sufficient. The other thing I would say is that in terms of the annual exam, the vast majority of cervical cancers and precancerous lesions of the cervix are related to HPV. So those can be prevented with the HPV vaccine. But there's a small subset of cervical cancers that are unrelated to HPV that are more faster growing and more aggressive that can develop within a 1 year time period. And so it's very important to have a trained eye that's looking at the cervix annually to detect any abnormalities that may exist.
Well, one of the things I want to bring to the conversation is, don't forget, the state of Florida is the third largest state in the union. And what does our population look like? Obviously, we have the highest percentage of people over the age of 75 of any state in the union. We have the highest number of people over the age of 80 of any place in the union. However, on the other side, we have the third or fourth, depends upon which year it is, largest K through 12 system in the United States. I'm talking about all of our K through 12 participants. So you have, obviously, parents who are of birthing age or post-birthing age. So therefore, you have this large population of female population that are not necessarily recognizing the opportunity they have to save their lives.
Well, interestingly, Broward County has one of the highest cervical cancer rates in the state. And for a multitude of reasons, there's many different risk factors that are associated with it. Screening, people not following up with screening, or just not knowing screening guidelines, or why it's important to see the different types of specialists or subspecialists in the various medical fields. But as you mentioned, there is a large population of women of various ages. Cervical cancer predominantly happens in people who are beyond age 30, whereas precancerous lesions can be earlier than that. But Broward County, like I said, does have one of the highest rates of cervical cancer.
Well, and unfortunately, Broward County also is one of the leading counties for on the issue of infant mortality, not only in the state of Florida, but in the United States, which is an unfortunate thing, and that's a subject for another show. What you said, Adrian, is that you want to be known as Adrian because it's that relationship you have with the patient, correct?
That's correct. You know, being close to a patient and kind of becoming one with, I would say, their extended family does confer doctors certain advantages. I think it increases patient compliance. You know, you are more apt to take advice from a close friend than a distant acquaintance. In my field, I feel that it's fostered a sense of collegiality, not only with the staff, but with the patients as well.
Yes, I'm sure you agree.
Yeah, I agree completely. And you know, as I tell most of my patients, I treat them or make recommendations as if they were my own family members. And I treat them like that. And I think it's really important for patients to know that and to have, like you said, a very good relationship with their physicians who are taking care of them and to trust them.
Well, you know, you both are presenting your professional services at Plantation General Hospital, which has one of the, it's not only one of the leading hospitals in Broward County relative to birthing of children, but one of the leading hospitals in the entire state of Florida in birthing of children. So the whole field of OBGYN and the subspecialties in the gynecologic area are very, very important to the venue which you are practicing in. So I think it gives you a great opportunity to present yourselves as the professionals that you are. We're down to the last 4 minutes of the show, but I want to get into something real fast. Do I assume that both of you ask or have patients of certain genetic backgrounds or otherwise? Do you ask them to be screened for BRCA?
Well, I think a lot of it, you know, we're learning more about genetics every single week, really, every day. And the discussion about who to screen for genetics is complicated because there's family history that plays into it, and then there's spontaneous mutations within someone's genes that can happen. So it's a very patient-dependent conversation that I have, and I do not recommend at this time that everybody be screened for BRCA. It depends on family history, it depends on personal history, and it depends on a variety of other factors as well. And so I like to work very closely with geneticists and also with the patients themselves to get a better understanding of who the right people are to screen for things like BRCA, although there's many other genes that we know now that contribute to ovarian cancer and uterine cancer. Interestingly, cervical cancer, there are genetic mutations that lead to it, but for the most part are not familial. It's not a familial disease and it's not passed on from, let's say, mother or father to child. It's more of an exposure to the HPV virus that kind of leads into the development of cervical cancer.
Okay, that's great. I just wanted to get that in because that, you know, we've had a couple of, I guess, notes recently from people that have been led to have full, you know, total surgical involvement. And I mean, I'll just leave it at that relative to BRCA.
You know, I can add one more thing. I mean, BRCA is talked about at the at the forefront for as far as genetic testing is concerned from a patient standpoint. And as John alluded, there are quite a few other mutations that are not talked about as much. This comes in at every annual exam when we speak to the patient about their family history and their own personal history, and we do formulate a certain score and a certain number, and then we send the appropriate candidates for testing.
Okay, well, I appreciate both of you for being here. I know that you work very, very hard, and you're very faithful not only to your patients, but to your profession, and we thank you for your advocacy. It's amazing to me that every time I sit down with an OBGYN, whether you're subspecialist or just, you know, the whole categorical entity, I feel good talking to you. So certainly not going to do an exam on me, but the bottom line is I certainly appreciate everything that you do. And thank you very much. And again, Dr. Adrian Roznowski of Plantation General Hospital, you're an obstetrician gynecologist. And Dr. Jonathan Black, Gynecologic Oncology at also Plantation General Hospital. Thank you both for being here. I know it was very opportunistic at this point in time to talk about it because there's a lot of action going on from the American Cancer Society these 2 months. Folks, I hope we answered questions that you presented to us, and if you have any comments or further questions, just get to this email address and our telephone number. And remember, this program is your program. It's called Dateline Health. And I always tell you before I close that you got to take good care of yourself. So these OBGYN specialists, subspecialists, and specialists in themselves as human beings are telling you that every female needs to be seen at least once a year. So make sure you take good care of yourself. Again, I come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.